Hi, everyone, and thanks so much for joining us today for Module 5 in this series of AHA's Conversations on Social Determinants of Health. My name is Dr. Rishi Manchanda, and I'm president of HealthBegins. This module will focus on transportation. I'll be joined today by Jill Lord, who is the Director of Community Health at Mount Ascutney Hospital and Health Center in Vermont, and you're going to hear from Jill a little bit later. But first, let's give an overview of what this module will review. First, we're going to approach the why. What is transportation as a social determinant of health, and what is the impact of transportation on health and healthcare? We'll then speak to the how, different approaches that are available to all of us to address transportation, including the use of upstream quality improvement, which we've discussed in detail on Module 2. And finally, we'll bring this all home, as I mentioned before, by bringing in Jill Lord from Mount Ascutney, who will share some really innovative work that she and her colleagues have been doing on transportation within her community, which happens to be a relatively rural one. So first, let's start with the why. Why do we care about transportation in terms of its impact on health and healthcare? Well, when it comes to social determinants of health, this is an opportunity to speak a little bit about the different frames of reference that we see individual stakeholders using when they talk about that term, social determinants. This is especially true for us in hospitals. Let's think about transportation as an example to illustrate this first point. When we think about transportation, it's important to think about what the frame of reference is for the stakeholder who's talking about social determinants of health. So from a social determinants of healthcare reference point, transportation means, does someone have a ride to a doctor or a ride to the hospital? That really is looking at transportation as a social determinant of healthcare access in particular. From a social determinants of health perspective, transportation wouldn't just be looked at as a social determinant of getting a ride to a doctor or a ride to a hospital. It'd also be thinking about whether an individual has a ride to childcare or to a job or to a park. That's a social determinants of health perspective. The frame of reference for health equity invites us to think a little bit more broadly. So instead of only thinking about transportation as a ride to a doctor or a ride to a job or childcare, the social determinants of health equity frame asks us to think about why there are only bus lines in one community or transportation options in one community versus another. It looks at the distribution of resources and the policy choices that inform them, and the equity, the parity between them. So that's how we use transportation to illustrate one key component here, which is what's the frame of reference? And as we in hospitals and hospital leaders think about social determinants of health, it's important to understand the frame of reference we're using, especially as we start to engage those in communities as partners. So for a lot of us, when we think about transportation and its impact on health, we know that there's a larger number of resources than ever available to help us think through the specific ways in which this social determinant impacts health and healthcare access. The American Hospital Association actually has created a guide on transportation and has actually done a really wonderful job in describing the specific ways in which transportation impacts health and healthcare. It reviews barriers like transportation infrastructure barriers. It also reviews costs and the costs associated with transportation. It looks at vehicle access, such as lack of a personal vehicle or lack of access to a vehicle through friends or family. It also looks at transportation in the lens of distance and time burden, such as long travel distances or lengthy wait times to get access to transportation. And finally, it looks at transportation as a policy. What's great about this particular guide and this framework is that it starts to unpack the different dimensions of transportation as a social determinant to be able to illustrate how it relates to health and healthcare specifically. And all in all, each of those 5 dimensions, infrastructure, costs, access to vehicles, the distance and time burden, and policy, all have an impact on healthcare in a few different ways. One, it can lead to missed doctor and clinic appointments. It can lead to limited pharmacy access and decreased prescription refills as individuals have limited access to even get to the pharmacy to fill that prescription in the first place. And lastly, it has an impact on the economic kind of burden for patients as well as the healthcare system because of those missed appointments or because of those missed prescription refills. All these roll up into direct and indirect costs and impacts on access to health and overall health outcomes. So as we think about transportation in all the different dimensions, in terms of how it impacts health and hospitals in general, we should look at the specific numbers in terms of the prevalence and the overall experience of transportation as a social determinant of health. We know that, for example, in the US, about nearly 4 million individuals do not have access to medical care because of the transportation barriers we just reviewed. We also know that regardless of insurance status, about 4% of children, approximately 3 million children in the US, miss a healthcare appointment each year due to unavailable transportation. That number goes up to 9% of children in families with income less than $50,000, clearly indicating that there's a disproportionate impact on poorer families. We also know that transportation is the third most commonly cited barrier to accessing healthcare for not just children, but for older adults as well. So overall, individuals who are older, who are less educated, female, minority, or low income, or have a combination of any of these characteristics, are affected more by transportation barriers than those who don't have those characteristics. We also know that veterans are vulnerable to transportation barriers based on the research, as well as children and older adults. And this may be a reflection of social isolation or comorbidities or a greater need for frequent clinician visits. So transportation challenges are manifested in many different ways, and it also affects urban and rural communities differently. So transportation clearly has an impact on health and healthcare, in particular on access to healthcare. The question now is, of course, what can be done about it? How do we look at transportation not just as a barrier, but as an opportunity to improve health of populations as well as communities? There is research, and this is the good news, that demonstrates that walkable and bikeable and transit-oriented communities, in other words, those communities who have been intentional about being more walkable and bikeable, are overall more healthy, as is this infographic from the Robert Wood Johnson Foundation states. This results in populations that are more physically active, have lower body weights, lower rates of traffic injuries, experience less air pollution, and overall provide improved mobility for non-drivers. It is possible to improve health in communities with better transportation options, as this research compiled by Robert Wood Johnson Foundation illustrates. So we know that transportation impacts health and clearly is important for healthcare access. The question now, of course, is what do we do about this? How can we go about addressing transportation? And we know that hospitals do have a role to play in addressing transportation. There are a number of things that hospitals can do to address patients' transportation needs and improve the health of communities. So you can see on this slide, there are a variety of different ways. One, for example, is to review data from the Transportation and Health Tool. This is a tool developed by the U.S. Department of Transportation and the U.S. Centers for Disease Control and Prevention, the CDC. This tool helps you to understand the health impact of an existing transportation system or even a proposed transportation project on the health of communities. Hospitals can also participate in local or regional transportation planning initiatives. These initiatives go by the names of Vision Zero. There's an initiative called Complete Streets, and there's others that promote livable community initiatives and smart growth approaches to transportation and development. Hospitals can even go so far as to invest in transit systems to improve health as well directly. Or for individual patients, they can participate in initiatives to screen for social needs and support the use of health impact investments. So for instance, the CDC has a transportation health impact assessment toolkit. And this is a toolkit that is geared towards community planners as well as hospital and health professionals to engage with stakeholders and account for future transportation initiatives. So clearly there are a variety of different ways, both for individual patients as well as institutions and even communities, that hospitals can address transportation. The question, of course, is how to decide what's the best way to implement these strategies. And that's, again, where upstream quality improvement comes in. We've discussed upstream quality improvement before, especially in Module 2, but let's review some of the basics. We know that there are basic questions for quality improvement. Questions like, what are we trying to accomplish? How will we know that changes have resulted in an improvement? And finally, what changes can we make that will lead to an improvement? We can use the basic fundamental methodologies to answer those questions, the basic methodologies of QI, to test social determinant interventions, especially to address transportation. One of the best and simplest tools to use is the PDSA cycle, the Plan, Do, Study, Act cycle. We know that you can run PDSAs throughout the development of workflows and that many of you do so on a day-to-day basis in your hospitals. There are many ways in which this can be applied to this question of transportation. So for example, when it comes to screening for transportation as a social need in your hospital for defined populations, there's an important question. Well, who's the best person to ask those screening questions? When in the visit should the screening be done? Should it be done at patient registration or as vitals are checked or prior to discharge or at checkout? These are really important questions that are very, very specific to your particular setting and your population and your staff. So when it comes to the ways to answer those questions, we think PDSAs offer a perfect tool, perfect method to be able to find out the best way to be able to address those questions. There are other questions as well, not just about how to ask about social needs like transportation, but to be able to help clinical staff and care teams assess the type of transportation needs, the type of transportation barriers, and also how to be able to guide their interactions with patients. So for example, it may be that a pocket guide could be helpful to help prompt care teams to be able to have structured and brief conversations with patients. Or maybe that a flyer in the exam room is an appropriate technique. Again, PDSA offers a methodology to be able to test out which technique or which approach might be more helpful to be able to drive the change that you seek. There's also at the question of referral, a good number of hypotheses that can be tested. What does referral look like when it comes to specific community partners? Again, there are many tests here for PDSAs that can be tried in your hospital setting to be able to implement an effective screening and referral workflow. Now, there's no better way to illustrate what PDSAs and what quality improvement overall and upstream quality improvement looks like in the real world than this presentation you're going to hear next from Jill Lord. It's really my pleasure to turn the mic over now to Jill Lord from Mount Ascutney Hospital and Health Center in Vermont. Jill, it's really a privilege to have you join us today. We can't wait to hear from you and your story about how you've addressed transportation as a social determinant of health. Jill?
My name is Jill Lord. I'm the Director of Community Health at Mount Ascutney Hospital and Health Center. My background is over 40 years as a registered nurse and in progressive leadership through 24 years as a chief nursing officer, and in the last several years working exclusively with community health. So Mount Ascutney Hospital and Health Center is a not-for-profit rural critical access hospital. We've been in operation since 1933. The hospital was built exclusively from funding raised through the community. And the community-hospital relationship has been strong and supportive throughout the history of the hospital's organization. We're a member of the Dartmouth-Hitchcock Health Organization, and we're committed to quality as demonstrated through certifications as a National Committee for Quality Assurance, the NCQA, for our ambulatory care, our patient-centered medical home. Also, we're a commission on accreditation for rehab facilities, a CARF-accredited facility for our rehab program. And we were both a finalist and a winner of the Foster McGaugh Prize for Community Health. During the last number of years, really since 1992, we've exclusively worked to identify community health needs and address them through an organized program with significant effort in grant writing and support from the hospital to address the myriad of needs in the community in the continuum of care from prevention to chronic care management, including alcohol and drug prevention, dental care, housing, improved nutrition, improved exercise, and strengthening families. This discussion on access to transportation is part of our program recognizing the barriers to health. And we believe that the social determinants of health are part and parcel of our mandate to promote the health and well-being of the community, and recognize that with the studies that have been done, healthcare assumes about 10% of the impact on your health and well-being, while social and emotional and environmental factors, such as transportation, have an impact of 20% or more. Why address transportation? It's a good question. And my answer for you is that when we've done our studies and through the community health needs assessment, we found that access to transportation was identified as an issue by both the community and the key leader surveys. It did raise issues from the community health status indicators as well. When we looked and analyzed the outcomes of that community health needs assessment, we found that lack of transportation was the number one most significant barrier to accessing services. 8% of our respondents said they had no way to get there, and that was the difficulty in accessing services. And 39.5% said that public transportation should be a focus, that we invested energy and time for supporting a healthy community. The 45 to 65-year-olds in the survey listed transportation in the top 5 of if you could change one thing for better health. So clearly we needed to address transportation as an issue. So in our journey of addressing transportation, we looked at what are the options that we could do to make a difference. First of all, what are the options? So we had to do some homework. We had to look at what are the range of transportation services that we could tap into for our community, and how could we communicate those so that people could utilize them for their maximum effect. So working with our neighbors in Springfield and the community health team, we developed a transportation algorithm that can be used by both professionals and by community members to select the best option for transportation. And this algorithm, using street signs and going through a progressive algorithm, takes the participant on a journey that allows them to identify the best transportation route for themselves. It explores what are their resources for family and friends to help drive them. What are the resources for Medicaid, and how do you access those? So phone numbers and the brief definers of 2-day notice, or what people need to do to be able to access those publicly supported transportation options. What are transportation options for those that are involved in the military? For elderly and disabled, for people that are visually impaired? What are the transportation options for local taxis? And I think those living around the country that are in rural areas know that that's a limited resource. However, there is some. So being able to list numbers and names makes it easier for people to get their transportation needs met. And we have a very strong volunteer base where there are riders, where riders can access volunteers who will give them rides to medical appointments through a program that we've developed jointly with the Vermont Public Transportation Agency called Rides to Wellness. We were able to get support for those volunteers so that we could at least pay mileage. We were able to get support for gas cards and vouchers for the taxi service. So it's a matter of looking at the existing resources in the community, organizing and communicating those resources in a way that's approachable for people in need. And then working with our community partners to be able to educate them so that those people that they come in contact with can, again, maximize those resources. So who are our community partners? When we looked at community partners, we looked at 211. the equivalent of 911 for social services. And we were able to work with those partners in 211 that's telephonic and also electronic access to people to zero in on what are the resources for their needs. Everything from food shelves and housing to transportation. So we provided our transportation algorithm to 211. We did education with them so that when people called, they were better able to help people find the best resource that met their needs. We worked with our mental health providers. We were able, through a grant, to be able to provide also gas cards to mental health providers and taxi vouchers, so that they were able to help people that are struggling and are challenged to be able to get to their medical appointments. We worked with community action and our economic services through the state agencies so that they were educated and could provide support. And we worked with our schools and our community health team. Working with partners allows us to maximize the impact of the program and work together in a neighbor helping neighbor approach. The results. So of that effort, I can share with you what the impact has been for our community. In the last year, our volunteers drove over 11,000 miles, helping 50 riders for 826 trips. We were able to provide gas cards, and when we did a survey of those people using the Rides to Wellness, 88% of those surveyed felt they were better off health-wise because of the Rides to Wellness program. Looking at the outcomes for the Rides to Wellness survey, the respondents said that if Rides to Wellness was not available, 60% would have skipped the appointment. One would have called an ambulance, and one would have said that they would have had to stay in the hospital longer. So these are all the indicators that we look at for decreasing healthcare costs and improving access to healthcare. So clearly, addressing the issue of transportation has had an impact on the health and access to healthcare. 46% responded that they missed or canceled a medical or dental visit because of lack of transportation. And 86% responded that they knew more about transportation because of the Rides to Wellness program. 100% of the people using Ride to Wellness said that it met their needs. So this was encouraging to us and was an indication that we were on the right track. You know, this is numbers, and we care about numbers. We also care about what's the personal impact. And so we talked to one of our care coordinators and other people that have used the program. And I just wanted to include a quote that the care coordinator shared with us. She said that if one of our patients is impeded by lack of transportation to their health provider, then it creates a snowball effect. Missed appointments can lead to a crisis visit in the ED via ambulance. And as a care coordinator, it helps to transport the patient to their appointments and to assist them in listening to what the provider is communicating and then ensuring the transportation is guaranteed for the follow-up appointment. So our system is more than transportation. It's a linkage to caring and professionals with significant expertise that can take the journey with the patient so that we can make sure they get what they need. Transportation can be a hidden barrier. This care coordinator stated, I sense that there are many patients who are too proud or too embarrassed to ask and say that they're unable to keep their scheduled appointment due to lack of transportation. So if the provider is not aware of this need as a barrier to treatment, they may assume that the patient is choosing to avoid the appointment or to pick up their prescription from the pharmacy. And we found, as we've delved into this issue and worked with folks, that it is more likely that the patient wants to make their medical appointment but is simply unable to. So linking these transportation systems and options with people in need allows us to help patients reach their healthcare goals and to work with us on those healthcare goals. I was asked to address challenges in the program. And so thinking about that and the journey we've taken over since the early 1990s, we've had to overcome that silo effect, or the fact that we are egocentric as a healthcare system, that we know best for the patient. And we've had to learn and in many cases be humble to understand that there are systems in place in our communities that we need to link to and learn from our community partners so that we can actually build an accountable community for health. We can set up a network infrastructure so that patients can have their needs met. We also have a challenge of evaluating success. As a small community hospital, we work with support from grants and on a shoestring because that's our financial situation. So we are limited. We don't have elegant or comprehensive data collecting systems. We rely on surveys and the data that we can collect through our EMR. And, you know, that's why one of the things that's helpful is also having the stories from people about what is helping and learning from those stories. Limited public transportation is a problem in the rural areas, so it challenges us to be creative and use non-traditional approaches. And so that's what we've done when we've set out our system, and we're continuing to learn and to evolve as we progress on this journey. Lessons learned. Well, it's important to think outside the silos. We can't do it alone. We shouldn't do it alone. We can, however, be a leader. We can be an integrator. We can be a backbone organization and provide resources to that network of community partners that can work together for the communities and the patients that we serve. Collaboration is our middle name, and partnership allows us to utilize resources to their best effect. And I think it has helped us to build strong and lasting, trusted relationships with our community partners so that we can better serve our community. That brings me to the end of my slide, and I look forward to discussing this in more detail with you.
All right. Well, Jill, thank you so much for that presentation. We wanted to spend some time just you and I just chatting a bit more to dig a little deeper into this really rich experience that you described with how a hospital can address transportation as a social determinant of health. I want to start by building on the last point you shared in your presentation, the lessons learned, especially lessons about collaboration and partnership. Clearly, collaboration with community organizations was key to the success of this, and it's continuing to evolve. I'm wondering if you could speak about how you have partnered within stakeholders within your hospital, including physicians and other leaders within Mount Ascutney. Could you speak a little bit more about the importance of those partnerships internally and what you've learned along the way?
Absolutely. We were a drug-free community, and that was in the 1990s. And one of the things that was stressed through that experience, and it was for 10 years that we were able to work with that program, was the work of collaboration and building partnerships. At that time, we formed what's called the Windsor Area Community Partnership. And we brought together stakeholders from the schools, from the law enforcement, from businesses, from health and human service agencies, all concerned about the health and well-being of the community. And that's been in operation for over 26 years. And through that time, we were able to develop trusting relationships that when we have a challenge to the health in our community and we want to develop a program that will address that and have an impact on that, we've been able to do that because of those trusted relationships. And having, we meet on a monthly basis. All partners can bring things to the table. I have to tell you that over the years, we've grown in our partnership network from the Windsor Area Community Partnership. We added what's called the Patch Network, which is health and human service partners that are operating out of the Windsor Connection Resource Center. We've added the Windsor Health Service Area Community Collaborative, and each of these networks works together because they're joined by the hospital being a common member from each of the networks and actually a leader of each of the networks. So when we had the issue and realized that we had to invest time and energy in transportation, we were able to talk to our community partners and say, how is this affecting those you serve and the work that you do? And how can we work together? And so as we built the algorithm, we were able to share that with our partners and they could give us feedback. We could share it again and we could evolve it from their feedback. Hospital, interestingly, our work with community networks didn't involve a lot of providers in the early days. And it's only been the last 5 years that our providers, physician leaders and physicians and nursing staff have really jumped into the fray to become part of this work. And we've done that through our Windsor HSA Community Collaborative and building an accountable community for health. And they've been able to really bring that quality aspect of health and wellness and outcome performance measures into the work that we've been doing, which now becomes a marriage and real partnership between the hospital and medical field and the health and human service agencies, businesses, law enforcement, and so on in our community.
I was going to build on that last point there, and it was fascinating to hear about the long history of kind of community partnerships and networks that have been built, and how that in some ways informed not only really great kind of collaboration in the community, but then informed the way in which providers, including physicians and physician leaders and nursing staff, could be involved in this program. You said they jumped right into the fray. Before we talk a little bit more about quality improvement, because it sounds like that was such a key part of the experience, especially in the past few years, I'm curious if you could share some stories about what it was like when those providers jumped in the fray. And I'm particularly interested because you mentioned that in one of the challenges that some providers sometimes don't understand or recognize that transportation can be a barrier to treatment for their patients. And I'm curious if you saw that evolving, if you have some stories to share about what that looked like as providers jumped in to help out with this issue to address transportation. What was it like for the providers within your hospital?
Well, I think that it's easy to for providers to be siloed and to see the first that patient in front of them, and then the next patient in front of them. And I think what has evolved over time is really looking at population health as our new frontier, and how we really needed to have a broader view of what health is So when they first, jump into the fray, it was really around performance measures like A1Cs, hypertension, diabetes, and now it's much more understanding and involvement in the community health needs assessment, which includes our priority of needs, which includes housing, transportation, nutrition. And so providers being involved in knowing and helping patients, I'll give you an example with nutrition. They have become one of our strongest allies in writing prescriptions for vegetables. And we have a program with the Vermont Food Bank called Veggie Van Go, where we have the truck from the food bank come once a month, and we hand out fresh vegetables to people in the community. And they are referring patients and talking it up and making recommendations, and are firm believers in a broader approach now. And that's made all the difference, because the power of the provider is so important. People listen to what their provider recommends to them. They have the trust in the provider. And so having a broader view and more involvement in this work with the social determinants of health has been very powerful for us.
Well, it seems like that's truly been kind of a transformative environment in which community partners, as well as hospital leaders and clinicians, are coming together to kind of reimagine the ways they can actually work together, and the ways they can work together on things that may sometimes feel out of reach, including social determinants like transportation. One of the things you've alluded to is the fact that putting that within reach was a function of the use of rapid cycle tests of change and PDSA cycles. Could you speak more to from your experience now using quality improvement methods, how important it was to use that type of methodology to build these types of relationships, especially when you think about building those kind of relationships between hospital leaders and clinicians, including physicians, and community partners? How important is quality improvement to this work?
So being able to address quality as a practical, evolving, and highly visible effort and process is important, because academic long-term research will not have an impact where we are in evolving the culture and engaging our community partners and our community members. But the PDSA cycles do, because what we can do with PDSA is take a concept, make it visual, and I'll use the roadmap as the Rides to Wellness roadmap as an example. We looked at that. The first one did not have roads on it. It had information crammed into every corner because we wanted to use it. And so we had to field test it. Is this readable? Can people use it? And so as we evolved that, we had, I can't tell you how many different iterations we had for the roadmap before we landed on what we thought was clear and effective. But we were able to field test it with people that are working with the patients, people that, with our community partnership. And by doing that, we also educated people about the direction, and we were able to receive the best of advice for people that are working directly one-on-one with patients and know what they need and know what they understand. So being able to be, I guess, again, I'll use the word humble, knowing that we're on a journey and what we use can always be better, and we need to listen to each other to make it be better. And the sum of all of the partners is so much greater than the idea that we started out with. So I think, just the process of using PDSA allows us to progressively improve quality in a highly visible way that has an impact.
Jill, what occurs to me as I'm hearing you describe the power of kind of PDSA, rapid cycle test of change, of continuous improvement methods, is that that it allows people to field test, and that field test, that ability to field test these things, is something that really resonates with a lot of clinicians. We're familiar with motivational interviewing. When a patient comes to us and they have what seems to be an overwhelming challenge, when they don't know exactly how to take on a major behavior change, quitting smoking, or improving self-management for diabetes, or whatever that major behavior change is. We know that motivational interviewing includes essentially field testing, small ideas. Let's test and see if this works, and with a goal in mind, and with a belief that these rapid cycle tests of change that are supported by a clinician for their patient can achieve real outcomes. It feels comfortable to a lot of clinicians, and I think what's interesting is how these kind of field tests that you did with the algorithm to created kind of a sense of increased efficacy among the clinicians themselves, as well as the other partners, to be able to do this, right? Instead of taking on transportation as a major policy issue, it sounds like clinicians were able to take this on by field testing, which is something that, again, we're pretty comfortable doing for our own patients. Does that resonate?
Yes, it does.
I'm wondering what it means then for you. This has been an incredible story, being able to learn about the work that has been happening at Mount Ascutney and with the community of organizations and clearly of residents that you serve. What has this meant for you, Jill, as you reflect on your role in this project and your professional career? You've clearly been a frontline nurse, a clinician, an executive, and I'm just curious what this means for you as you reflect on your role, and what it means also about your perception of what the role of a hospital is, and when it comes to addressing transportation or other social determinants.
It has been enormously satisfying, because I've been able to develop partnerships and trusting relationships with a diverse group of both agencies and individuals that can catch the passion of having an impact on health. As a clinician, and you look at the facts and the data about the chronic disease burden, about really needing to reduce healthcare costs, it's freeing to know that you can work with others who actually will support your efforts. And it's so satisfying. I think, if I think about it, being able to facilitate those dialogues and then see the outcomes in real tangible ways that impact the quality of people's lives, it's very exciting. And for my whole career as a nurse, I've always yearned for emphasis on prevention instead of solely receiving the ill and the injured, to make a difference so that they actually don't have to seek our services. So it's freed us to put more emphasis and time and energy in that area of prevention, and to gather other people along the way that can work with us. The hospital has a natural role as a leader in the community for health. I think people, nurses continue to be the number one trusted profession, right? And so both nurses and physicians, when we put ourselves in that place of integrating with community services, with drawing people together from diverse backgrounds, and simply inviting them and hosting the conversation and facilitating the work forward. It's a natural place for us to be, and it's a role that we can effectively play. And for myself, it's been enormously gratifying. I love it. I'm never bored. And I always have a goal, because it's endless what needs to be tackled in promoting the health and well-being of the community. We've been very fortunate in Vermont to have structural resources in terms of the Blueprint for Health, which is an amazing social service, and human service and medical best practice to transform healthcare. And we've been part of the Blueprint for Health from its inception. So we've had learning collaboratives so that we've been able to learn best practices and then implement those in our communities. And the other aspect is our ACO One Care Vermont. Being part and parcel of that dynamic transformation of healthcare. This is the place where we need to be right now in healthcare, and to see it unfolding before our eyes is enormously exciting, and it's a very meaningful way to spend your time and feel like you can have an impact. I haven't talked about collective impact, but that whole body of knowledge around how, when you can integrate and be the integrator, bring people in, foster collaboration, maximize the resources of all of your community partners into one effort that avoids duplication and also gaps in care. That collective work together has such a powerful opportunity for influencing the health and well-being of our communities, that it's been a privilege to be part of that.
Well, Jill, I can't thank you enough for sharing your story and the story of everybody that's been working on this issue. This issue is transportation. You've used words just in describing what this has been for you, enormously gratifying, freeing. You even, I think, mentioned love in the sense that you love this work. In describing this, and I think it clearly is something that is inspiring for me to hear, and I think will be inspiring for a lot of folks who are going to be listening to this to also hear about the transformative way in which working on transportation can impact somebody who's involved in this, especially being in a hospital system and reimagining what it means to be a true, what we call an upstreamist, somebody who's able to really focus on prevention and community and leverage their privilege to be able to make it happen. Well, Jill, thank you again for a wonderful conversation today about transportation as a social determinant of health as part of the fifth module in the AHA conversation on social determinants of health. I think through today, hopefully all of you have been able to learn something and gain something and thought about at least one test of change, one strategy to implement to be able to better assess and address patients' transportation needs, as well as to improve the health of your community. I want to thank you on behalf of the American Hospital Association and certainly on behalf of HealthBegins, and invite you to continue this conversation on transportation and the ways in which we can move upstream together as hospitals and health systems to address transportation by being able to tweet at us. The tweet handles are listed here, and of course, remaining engaged in this series as well as other resources that the American Hospital Association and HealthBegins will bring you. Again, thank you for your time today. Looking forward to the next conversation.